I'd like to thank the Pontifical Academy for giving me this opportunity to revel in this splendid place and to have a chance to speak with you a little bit about my approach to precision or personalized medicine. I'm going to bring us full circle, if you will, and start in a way where Lee Hood began at the beginning of the day. And that is to think about what it means to be able to capture these arbitrarily large data sets. And fundamentally, the goal at the end of the day is if we have very, very large data sets and deep, deep knowledge about the health and wellness status of individuals, what we'd really like to be able to do is intervene in such a way as to ameliorate disease or improve well-being. And that turns out to be an enormous challenge. So I'll speak with you about the challenge of intervention, but the general framework of my talk this afternoon will be as follows. I will first be a cheerleader for all of the great things that have been accomplished over the last 50 years, because a lot has been accomplished, and the nature of disease and medical intervention has changed quite dramatically. I'll then talk about why there is reason to be pessimistic about our continuing ability to intervene in that same way, which has to do with the nature of the diseases that we hope to actually affect. And then I'll return at the end with a little bit of an optimistic fillip that will lead us, I hope, to conversation and then to dinner, which I know we all want. So let me begin then by saying that there's a lot that's happened in the last 50 years. And for those of us who trained in medicine 40, 50 years ago, that what we learned at the time, which is shown in the top graph, is that the conquest of infectious diseases had an awful lot to do with improvements in life expectancy. And that's shown in the line that goes up from left to right, which shows the improvements in life expectancy. And the green sort of solid fill, and this is taken from US data, the green solid fill indicates the decline in deaths due to infectious diseases. So life expectancy from birth shown in the solid line, and the decline in deaths secondary to infectious disease. And much of that improvement in life expectancy and the decline in deaths due to infectious disease was, as you know, due to improvements in sanitation and nutrition. That's really what had the greatest effect. And the expectation was it's hidden by a white bar that I introduced. The expectation was that actually life expectancy from birth would flatten out thereafter. But it didn't, and if I remove that bar, you'll see that actually, as we continued into the 21st century, life expectancy at birth continued to improve. And the reason why life expectancy continued to improve, life expectancy at birth continued to improve, has been analyzed over a long period of time now. And what we can say is it has an awful lot to do with pharmacologic intervention. That includes, of course, childhood vaccination, which has had a big effect on incidence of disease. But beyond that, it's also included important interventions that have dramatically reduced certain classes of disease. So, for example, if we look at the recent reductions in mortality, those result in large part from pharmaceutical interventions. And the slide is on this screen is a little bit too difficult to see, but I'll just point out that this is represented from the National Center for Health Statistics for the United States. And what it shows is a breakdown of deaths per 100,000 people plotted over time as a bar graph. And what you can see is each one of those colors represents a different class of disease. At the very bottom, there's pneumonia is represented, and it's in sort of a magenta color, and it doesn't change much over the 7 decades that are represented there. On the other hand, if you look at the light blue color, that's heart disease. For all of us who were involved in clinical practice in the 1980s, we know that the most common discharge diagnosis from all American hospitals was rule out myocardial infarction. There were large coronary care units at that time, and there was an awful lot of heart disease and an awful lot of heart disease-related death. There's been some effect on heart disease secondary to reductions in smoking and to changes in nutrition, but frankly, the big effect on heart disease has been the introduction of effective therapies, most particularly effective means of lowering blood pressure and the reduction in LDL cholesterol, as well as instrumentation, that is stenting and other surgical procedures that have reduced the impact of coronary artery disease. The reduction is dramatic. There's a threefold decline over this period of time in deaths per 100,000 population. But you can see that decline is most dramatic for heart disease and much less dramatic for other categories of disease. For example, there's really been not much change in deaths that are assigned as secondary to diabetes, despite the fact that heart disease is a major complication of diabetes. And similarly, there's been a relatively small decline in cancer, which is the top blue color. Deaths due to heart cancer haven't changed very much. And until recently, therapeutic interventions for cancer, except for the hematologic malignancies, had modest efficacy. So the reality is, as demonstrated both by childhood vaccinations and by effective therapies for coronary artery diseases, great drugs really can change the world, and they can do that both in Western societies and also what are called less developed societies. So in both settings, we've seen these kinds of changes. One example of what a vaccine can do is the recent introduction, relatively recent introduction, of the human papillomavirus vaccine, originally as a 4-valent vaccine and now as a 9-valent vaccine. And we now have 10 years of experience with the introduction of the human papillomavirus vaccine. Data, particularly from Australia, as well as from the United States, show just how dramatic papillomavirus vaccination in adolescent girls and boys, just how dramatic those effects can be. This is, again, data from the US, but the data, as I say, are even more dramatic in other countries where vaccination is practiced more effectively. But a 65% reduction in the incidence of HPV infection for those who received the quadrivalent HPV vaccine. And as I said, in 2014, the 9-valent vaccine was licensed. Societies are coming to terms with the idea that papillomavirus vaccination can actually result in the elimination, if not the eradication, of papillomavirus-related disease. And there's so much enthusiasm for this now. I'll give you a feel for it. It took us 10 years to gain registration for the papillomavirus vaccine 4-valent in China. That data set was reviewed for 10 years. The 9-valent papillomavirus vaccine was reviewed by the Chinese medical authorities in 8 days. And the reason was because of the dramatic evidence that has accumulated over the last 10 years that papillomavirus infection is actually controlled by this, and the desire on the part of the Chinese government to introduce these more effective vaccines into the Chinese population. In order to actually control papillomavirus around the world, this requires that we be able to produce enough vaccine to immunize the entire birth cohort of the world, and actually to do it twice, since it's recommended that you receive 2 doses of HPV vaccine. So that's 200 million doses a year, and unfortunately, we don't have enough manufacturing capacity to come even close. But we're in the process of building that, and over the next 5 or 6 years, we should be able to get to the point where we could actually do that and test the question of whether or not it would be possible to eliminate this disease. As it turns out, the evidence is quite strong that not only would we be able to get rid of cervical cancer, for which the HPV vaccine was originally registered, but as well about 50% of head and neck cancers are caused by HPV. And the expectation is, and we have data to show it based on surveillance, that we would begin to see those decline as well. So it can be a quite dramatic effect as a result of a vaccine that is otherwise innocuous. I say that, and it's important to emphasize it, because probably the thing that is most significant in trying to implement this kind of broad-based public health intervention is what is called, sort of genteelly, vaccine hesitancy. but what really represents a very active political attempt to block vaccination, and that's occurring around the world, interestingly in relatively educated segments of society, for example, in Marin County, California. So just something that we have to deal with. It represents an attitude within the public domain about interventions, medical interventions, and vaccines in particular, that it's important for us to understand going forward. But I would like to return to the issue of cancer beyond the question of prevention, and of course cancer prevention is what we would ideally like to do. But in most cases, cancer arises seemingly from stochastic processes. It's a somatic genetic disease, and those mutations that occur predispose cells to behave in a malignant fashion, to grow in the absence of growth factor stimulation, to grow without substrate adherence, to metastasize, and ultimately that has lethal effects, although the actual mechanism of lethality remains unknown. We've recently had a breakthrough in the treatment of malignancy, and that comes from work that began really 50 or 60 years ago. It actually comes from the understanding of transplantation tolerance that was pioneered by Peter Medawar initially in Australia, and subsequently was examined by many researchers around the world who came to recognize that there was a phenomenon whereby cells that had sustained mutations could, in principle, be eliminated. This was actually presciently articulated by Bob Good, who was for a brief period the president of the Sloan Kettering Cancer Center, who was on the cover of Time magazine in 1973. This is the picture of that. And he, at the time, said that his experience was that evaluating patients with cancer, there was always some aspect of them that suggested that they had a disturbed immune profile. And he referred back to sort of cocktail party conversations. I guess if you go to the right cocktail parties, you have these conversations between Lewis Thomas, Peter Medawar, and himself, in which the statement was made that transplantation immunity, as defined in Medawar's analyses, must play a major role in the body economy, and at that time he imagined it was cancer. I would say the reaction of the scientific community to this was not enthusiastic. And there were a lot of reasons not to be terribly enthusiastic about it, but it turned out to be pretty close to on the mark. And basically what we've learned over the last few years is that there exists on T lymphocytes, shown here in blue, a set of activating and inhibitory receptors that influence the way in which they interact with tumor cells, shown at the bottom. And in particular, one inhibitory receptor, which is called PD-1, when it is blocked, which you can do with an antibody directed against PD-1 or against its ligand, PD-L1, will permit a T cell to interact more directly with a tumor cell. What these antibodies do, these antibodies directed against inhibitory receptors, is they reveal the pre-existing immunity in some cancer patients that permits immune cells to destroy tumor cells. They do not cause the immunity to appear. They reveal the fact that it was already there. And the effects can be pretty dramatic, and PD-1 is the most dramatic, although other inhibitory receptors, for example, CTLA-4, work as well. So this is an example of what you see when you treat a patient with an advanced malignant disease with such an agent. And here you're looking at a patient who has intrathoracic metastasis from cutaneous melanoma. It's a CT scan, which you can view as a slice through 3 dimensions with the patient's feet pointing towards you and the right hand of the patient then on your left side. And you can see the top of the rib cage and the heart and great vessels. And there's this big mass that's present in the left lung field and adjacent to the center part, the mediastinum. This is in a 72-year-old man whose melanoma had progressed despite best available therapy and was near death on oxygen support. received a PD-1-directed antibody, and in a relatively short period of time, just a few months, that tumor resolved almost completely. So the image that I would like to have you in mind, this image, of course, but perhaps more easily, is former President Jimmy Carter. Jimmy Carter, at the age of 91, was diagnosed with widespread malignant melanoma with metastases intracranially, intrathoracically, and in the liver, was treated with this particular drug, MK-3475, now called Keytruda, and the tumor resolved completely. He is now the longest living American president at age 95, and has no evidence of disease. Which is kind of remarkable for all of us who've worked on developing cancer therapies for many, many years. Frankly, none of us have ever seen anything like this. And the other thing about it, aside from its effect on patients who have these very large, bulky tumor masses, the other thing about it is that it is the first broad-spectrum anti-cancer agent ever introduced into clinical practice. These agents actually act on a whole wide variety of tumors. And the responses, when they occur, tend to be durable. And to give you a feel for how they interact, this slide is an amalgamation of clinical results, again shown for this MK-3475 molecule called Pembrolizumab here, looking across the set of different tumor types for which data are available. These are called waterfall plots. And basically, it's a measure of the sum of linear dimensions of the tumor in the individual. And what you're asking is, from a baseline measurement in that individual, what happens after treatment? And so you scan at baseline, you treat, and then you scan again, and you ask, did the tumor grow or did it get smaller? And if it gets smaller, the green bar goes down, and if it gets larger, the green bar goes up. And you can start on the top left with melanoma. There's non-small cell lung cancer, head and neck cancer, urothelial tumors like bladder tumors, triple-negative breast cancer, gastric tumors, et cetera, et cetera. And over and over and over again, you see that a proportion of individuals, not necessarily the majority, but in some cases the majority, have tumors that shrink, and in many cases the level of shrinkage is dramatic. So that's true, for example, for melanoma in the top left. It's true for otherwise refractory Hodgkin's lymphoma, a very responsive tumor. It's also true for primary B-cell malignancy in the mediastinum. And it's also true, interestingly, for the class of tumors that have a genetic abnormality. It is the instability of the genome that can be recognized by looking at for the presence of microsatellites. That is, that there is instability of microsatellites, and microsatellite instability is associated with a response to these agents. In a very high percentage of cases, the drug is registered in the United States and in Japan and in other jurisdictions, though not in Europe, for the treatment generally of patients with tumors of any type, from any source, in any situation where there is evidence of microsatellite instability, which can be measured using commercially available tests. It's a very broad spectrum agent. So great drugs really can have a pretty dramatic effect, and even in the malignancy case, pretty dramatic. And our sense is that we have the hope now, for the first time, of bending the survival curve using immunotherapy to treat cancer. Whereas in the past, administration of standard chemotherapy might slightly alter the time to death. There is a durable response in many patients with malignancy, including quite elderly patients, that lasts for many years through immune manipulation. And our hope is that we can combine different therapies to improve that still further, that is, to have a higher percentage of patients with malignancy respond. There is some evidence that that's true, for example, in the non-small cell lung cancer case, and I'll just show you one plot that is data derived from a recent study in which patients were treated either with traditional, these are patients with non-small cell lung cancer, they were treated either with traditional chemotherapy in the black line or with the combination of chemotherapy plus immunotherapy shown in green, and the improvement in overall survival is quite dramatic on an intention to treat basis, and that improvement now, as years down the road, continues. My friends in thoracic oncology are opening clinics to see patients after they've undergone their treatment, which is a novelty for them since in the past none of their patients survived long enough to actually be seen in continuity clinics thereafter. So it's really quite a dramatic change that's occurred as a result of introduction of these new therapies. But now, having said all these good things, and I do want to emphasize the good things, emphasize the fact that the pharmaceutical industry, a collaboration really between academic researchers and for-profit companies that can introduce sufficient resources to actually bring new therapies to the market. The pharmaceutical industry accomplished a lot from the time of the original identification of effective antimicrobials. But Jürgen Drews, when he was at Roche, began publishing articles in the 1990s saying, you know, there appears to be an innovation deficit in pharmaceuticals, and what he pointed out was that the number of new chemical entities, which is a measure that is used by regulatory agencies to describe progress in the pharmaceutical industry, that the number of new chemical entities produced by the top at that time 50 pharmaceutical companies, who could imagine that there were 50 pharmaceutical companies, was insufficient to support the growth of these companies, and that new technologies, and he referred to a few at the time, didn't seem to be changing that at all. And indeed, if we look now, 20 years, more than 20 years, 25 years since he began talking about that, that seems to be true. And this refers to what I've called the evolving challenge profile of the therapeutics industry. Namely that if you look back to 1980 or so, there were really very, very few interesting targets to pursue, and there was room for quite a lot of drugs directed against those targets and quite strong intellectual property related to the drugs and in some cases the targets. The figure illustrates something that we might call, I guess, a figure of merit in engineering speak, which is some integration of complexity and challenge and pace that we plot over time. And I've arbitrarily drawn it as sigmoidally shaped and with that steep slope. But it's certainly the case that when you arrive in the 21st century, there are now thousands of targets, but we don't know what any of them do. Success rates in making drugs against those targets are clearly declining. Very rapid generic penetration, which means it's hard to support investment in these things, and there have been many devastating product failures. And indeed, if you look at that, what you know, and what many of you know very well, is that there has been a monotonic and exponential decline in productivity in the pharmaceutical industry that's been going on for decades. So this is an analysis that Peter Tolman at BCG and Bernard Munoz have conducted and published in a variety of settings, including in Nature, showing the number of new molecular entities or new chemical entities per $1 billion in research spend over time. And this is integrating over the set of pharmaceutical companies and small biotechnology companies that do that sort of thing. And what you can see is that you've got quite a few new chemical entities that were registerable in 1950 for your $1 billion of spend, something like 30 or so. But we crossed the $1 billion per new drug candidate time roughly around 2000, and it's been going down ever since. And though the curve is somewhat hectic and there's quite a bit of variation around the regression line, nevertheless you can see that it's been pretty much a straightforward downhill slope. And so we arrive in our current decade with a very difficult situation where it is hard to identify places where you can intervene and have any hope of getting a meaningful return on the investment. Clearly, if it costs multiple billions of dollars to bring a new drug into market, in order to get a return on that investment, you have to make that same multiple plus some increment, which represents your cost of capital. And I don't have any personal experience with it, but I think if you take several $1 billion to an investment bank, you can actually get a pretty good return on that investment. So as a result, that means you have to do better than that. So the period of the last decade was an example of what happens when you can't do that. It was a disaster for the industry. About $400 billion in valuation of the industry was shredded. About 300,000 people in the United States lost their jobs. And there was massive consolidation. And everything that we've seen in the current decade indicates the same thing is going on. It may be worse. A little bit later this week, Bristol Myers will close its transaction acquiring Celgene for about $90 billion. Bristol Myers is a perfectly healthy company with a good portfolio, but their view obviously is that they're not going to be healthy for too much longer, because if they thought they were going to be healthy, they wouldn't be spending $90 billion to acquire a portfolio from somebody else. And that same kind of phenomenon is occurring everywhere. How bad is it? Well, Matt Herper from Forbes did an analysis in which he looked at different companies and said, gee, how much R&D spending is there per drug in billions of dollars? And you don't need to go through this analysis, but the companies that do best are close to $4 billion, and some companies, AstraZeneca is the outlier on the far right, have spent close to $12 billion per drug. Clearly, you cannot make a living if you spend $12 billion bringing a drug to market. There is no way that the area under that curve is going to support your business. Within the pharmaceutical industry, there's a general air of pessimism that we're going to be able to discover new drugs that will actually have a meaningful impact on human health. There are many reasons why that is true. But it should be recognized that this is not a new phenomenon. Our inability to produce new drugs is well documented by the logarithmic decline in productivity that has been occurring for 7 decades. What's happened as a result is that pharmaceutical companies have tried to focus on things where they have a better sense that they might be successful. And the place where they might be successful is in the orphan or ultra-orphan category, because there you actually know what the cause of the disease is. And I would submit to you the reason why we're so inefficient and ineffective in pharmaceutical discovery and development is because we really have no idea how the human machine actually works. And since we don't know how it works, we have no idea what's wrong with it when it's broken. And since we don't know what's wrong with it when it's broken, it's a bloody miracle anytime we make a drug that has some beneficial effect, right? Because we have no idea. But if you look at the ultra-orphan diseases, where you have, for example, an inborn error in metabolism that makes it impossible to make a particular enzyme replacement makes a lot of sense. And you can register enzyme replacement drugs, and similarly anything that would correct a genetic defect, and in that way is a precision medicine that's highly personalized, in that way has a much higher likelihood of success. This graph shows you from FDA's data from 2009 to 2018, the number of new drugs that were approved in the United States, and the United States is the leading approver of drugs, over that period. And you can see that there's, sort of a general trend that a number of new drugs is getting larger. There's the average number of new drugs approved prior to 2008 was around 24, 25, and it's continued along that way for a long time. But recently we've seen an increase. That increase, however, is driven by the dark blue part, which represents the orphans. And in 2018, more than 50% of the new drugs that were approved were for orphan diseases. So let me say that again. In 2018, the majority of new drugs approved are directed against orphan or ultra-orphan diseases, and hence are not going to do an awful lot of good for very many people, right? They will be quite effective for rare populations, but they're not going to, from a greatest good for greatest number point of view, these are unlikely to have a big therapeutic impact. And Chris Austin will tell us a little bit more tomorrow morning about the kinds of things that can be done in focusing on ultra-orphan diseases. I mention all of this because as we acquire big data sets and we find deviations from what we call a normal population health, paying attention to define what that normal population might actually be, and having appropriate controls, it's not so clear that we will have drugs available that could intervene that might actually do some good. Without having a deeper understanding of the underlying physiology, the mechanism whereby a change in analytes or a change in genetic structure affects health, it's very difficult for us to design new drugs. As an example, one wonders, had we not had a thorough exploration of the phenomenon of LDL cholesterol levels, which started, of course, with the Framingham study in the 1950s, implicating cholesterol levels and risk for cardiovascular disease, with the observation that there were individuals with familial hypercholesterolemia, which led Mike Brown and Joe Goldstein to do their research, which ultimately defined the LDL receptor, but at the same time also led people to make HMG-CoA reductase inhibitors, which they thought were acting on the rate-limiting step in cholesterol biosynthesis. They were not, I mean, they were, but that's not how they work. At any rate, all of that work led to the availability of effective therapies, including both the statins and as well antibodies directed against PCSK9, which affects LDL cholesterol receptor expression. Those things came from a mechanistic understanding of cholesterol regulation in human beings. And if all you had was the genetic data, it would be extremely difficult to get to those kinds of interventions. And that, I think, is a plea for an understanding that this is really, to Eric Lander's point, just the beginning of our analysis of these large data sets that will ultimately enable us, I hope, to be much more effective as drug discoverers. Or that's what I hope to see when I'm watching from the nursing home. If I could, then I will point out again this problem of 60 years of exponential decline in productivity as documented on this graph, and try and dispel the gloom that has descended on our proceedings as a result of the fact that we're so damn ineffective at doing this. I would say 50 years of scientific progress conclusively demonstrate that great drugs do change the world. There's no question. And that's true for the childhood vaccines, of course. No one would dispute it for antibiotics, although we are living in a world where the discovery of new antibiotics in a world with antibiotic resistance because of inappropriate antibiotic stewardship is especially challenging. So I'm not that positive about that. Antihypertensives were clearly very effective, cholesterol-reducing agents, anti-neoplastic agents. All of those things are great, but somewhat paradoxically, these larger data sets are accelerating the industry focus on rare diseases because they're mechanistically simple, because there's very strong patient advocacy, because the treatment effects are very large, and that's important for us in the pharmaceutical industry, because without large treatment effects, there's very little hope of us being able to demonstrate important biology in the clinic. And with large treatment effects, we can do small clinical trials. They're often supported by patients' families. It makes it much more easy. And they're actually straightforward health economic arguments, although those health economic arguments put you in some deep water. Because you look at a child who's being treated with enzyme replacement, the cost of that enzyme replacement is very, very large over the lifetime of the individual. However, if you count the economic productivity on average of that child over their entire lifetime, it's also a very large number. This is the sort of thing that leads companies like Novartis with a recent therapy for spinal muscular atrophy to say, well, the cost is $5 million per injection. And, you know, sure, you can make a health economic argument, but it's not actually sustainable from a societal point of view. And we really need to have a much deeper dialogue about what makes sense in those kinds of contexts. So with that, I would just say that we can expect to get things from large data sets that are really important. You know, the technological advancement that we're seeing will improve our scientific understanding. So improved scientific understanding will provide a basis for developing new therapies. And I've just listed some of those improved areas here. You could come up with a longer list yourselves, but you know, single cell inventories, as we look at them, single cells in isolation, are revealing important novel aspects of human physiology. Some of that, for example, being the effect of sex-regulated loci on the autosomes, which can be seen on a cell-by-cell basis. A high-resolution map of human neuronal connectivity is going to provide astonishing information which we can't even characterize at the present moment, and it is going on at the present moment. Cubic millimeter by cubic millimeter, human cortex is being examined, and we're going to learn a tremendous amount from that. There's already a nearly complete map of the 50,000 neurons of the vagus nerve and all of their interfaces within the gastrointestinal tract. There's a lot to learn from this. And wearable monitors, as many of you know, some from personal experience, which are endowed with much expanded capabilities, permit real progress in preventive medicine and correlating behaviors with improved health. So all of those things are going to be very important and ultimately will lead to a lot of great stuff, and you could again provide a much longer list than this, but I think we're going to see totally new therapies for neuropsychiatric disease where to this point there's frankly been very little progress. I think that won't necessarily come, by the way, from the genetic loci that Eric described. It's nice to have those loci because they provide a leverage point for understanding abnormal physiology. The early diagnosis of and prevention to treat dementing illness is something that Lee Hood talked about and something that I think will ultimately come to pass. But all of these new discoveries, as everyone here recognizes, will both enhance and complicate the fundamental economics of human civilizations in ways that I would be delighted to hear your speculations about. Thank you very much for your attention.